Thank you, everybody, for the invitation to speak. I'm François. I'm a professor of medicine based in Central Johannesburg. My background is important in terms of the context of giving this COVID-19 vaccine talk. My research focus is very much within HIV, although more recently in the non-communicable diseases field, both of which obviously have some sort of overlap with COVID-19. I haven't been involved in vaccine development, although I think all of us have been forced into becoming semi-experts in the infectious diseases field. And what I'm going to talk about today is my experience with special groups from the HIV perspective and how this can be applied to COVID-19. These are my disclosures. I'm part of a group of HIV optimization scientists and public health and activists and researchers who are all looking to make drugs easier and safer and cheaper. And the other disclosure, which I think every single one of us feels at the moment, is I'm almost terrified of giving COVID-19 talks because by the time you've given them, they're almost out of date because the kind of information that's coming at us is just unprecedented. I used to think this was the case with HIV, but with COVID, it's that much worse. So just with that caveat, something might have come out that makes what I say here completely wrong. I hope not, though. So what is a special group? Now, firstly, I'm not going to be discussing variants. I think that's for somebody else's talk. And the special groups we talk about are not the same for HIV as they are for vaccines. With HIV, we have quite a broad group of well-characterized groups that we always worry about. Whenever we talk about guidelines or what we're concerned about in terms of side effects or dosing or whatever it is, these are ones that kind of make the list. And pregnant breastfeeding women, as specifically they tease out breastfeeding women because of the transmission risk of HIV to the fetus. Women themselves as a group are seen as important, and I'll talk about that in a moment. Race plays a role. Some of the side effects, one of which I'll talk about very briefly, plays a role. And then whether somebody is advanced HIV and has a high viral load, some of the drugs are less potent with more advanced disease. We often say about the type of there, look at adolescents and pediatrics as a special group, specifically again because the dosing of antiretrovirals to get right is obviously absolutely critical. And then for underweight patients, there has more recently been a concern that some drugs might not work. This is not a major concern, but it has been aired here and there. And then finally, all the co-infections that go with HIV, specifically hepatitis B, C less so because of how effective the therapies are, and then TB because of the drug interactions with the rifampicin drugs. So HIV is a lot to think about. Vaccines also does, and there's a lot of overlap here. Again, pregnant and breastfeeding women, adolescents, pediatrics. But in the group now we've tasked is a group of immunosuppressed patients. And this obviously refers to all the patients. HIV in my field, my area of the world, is obviously a major, major concern. But anything that's used for disease control, in, say, for instance, in the rheumatology field, the oncology drugs themselves are often very potently immunosuppressive. And then finally, there's a concern around older patients. And I'm going to be talking about all of these specific areas. So I'm going to give you a strange segue here into something that happened in HIV in 2019, which is why do we worry about special groups quite so much? And Andrew Hill and a group of UK scientists put out this paper in 2019 after a couple of reports of weight gain on antiretroviral therapy. You need to understand, if you're not in the HIV field, you must recognize how bizarre this is. You know, HIV is, it was called Slim's disease for a reason in the 1980s when it came out. And those of us involved in the field are often used to dealing with patients who've lost a great deal of weight. And suddenly this idea that HIV treatment could be causing clinical obesity came out. Now, Andy and his colleagues actually drew this out, and there have been many other studies since to support this, that actually people who start on modern antiretroviral therapy start gaining weight. We did a study that called Advance, and there was another one that called DAMSA that was published that demonstrated remarkable gain in weight in Black women. And as you can see, in terms of those special groups I was talking about earlier, this is really weird. Like, why would Black women gain weight more so than white men? And why Why was it picked up in investigator-initiated study rather than in the registration studies? This slide, I'm afraid, has been somewhat corrupted, but it gives you the sense that these, as I said, this is the subgroup from ADVANCE, demonstrating this remarkable gain in weight after only 2 or 3 years in the one arm of the one antiretroviral regimen. These 3 antiretroviral regimens, for those of you not involved in HIV, are the regimens that have been used in the last 10 years in both rich and poor countries, but huge gain in weight. So the question is, why was this not picked up in the registration studies? These studies allowed these drugs to be registered and then put into guidelines for the next few years. And part of the reason why is that the registration studies were largely done in gay white men, not in black women or in black men, and in fact did not represent the kind of demographic of the people that they were going to be used in. Even in places like the United States, if all you did was take the Europe and the United States, the demographic didn't fit. The patients that were recruiting for the registration studies did not fit. And this just demonstrates the importance of doing studies in the group that are going to be used. And I'll talk about this again in just a moment, the reasons for it. But even in there's been huge focus in antiretrovirals on pregnancy. There are a lot of studies are done on pregnant women are excluded from these studies. So it's not like with black women where it was just the recruitment strategies must have favored white men, but pregnant women are actively excluded. The pregnancy tests are done repeatedly, and often if women become pregnant on studies, they are kicked off the study. And this has meant that pregnancy data is always a Johnny-come-lately. It plays catch-up all the time with this. I'll talk about this in a moment. And this focus, though, on pregnancy and on demographics with the HIV world is starting to gain currency, as it's not acceptable anymore to have studies which overly include white males when a large proportion of the black population are going to have access to these drugs. But also more and more anger actually at the fact that there isn't data when new drugs are registered, that there isn't data on pregnant women. So I just wanted to pause there for a moment about the vaccines. Now, one of the things I've realized, having some of my best friends are vaccinologists and virologists, is that the philosophy is different. And partly that's because you need to understand is that when you vaccinate somebody, you're giving a drug essentially to somebody who is almost always completely healthy. It's the same as in the contraception world, that that the tolerance for side effects in those populations with vaccines or with contraception is much lower than, say, for antiretrovirals. But one thing that large statement I just want to say is that I actually think there's something philosophically profoundly different about vaccines coming from the HIV world, is that this tolerance for side effects is almost, I can't understand why it is so low. For, in HIV, you give drugs that have real known side effects and costs, and you weigh that up against the benefits. And that weighing up is getting harder and harder as the drugs get safer and safer and more potent. But the sort of exaggeration of care that you see with vaccines is almost, I can't actually understand it as a developing scientist. Even but when you measure it against the contraceptive field, it's difficult to understand. And particularly where you're not dealing with a mild disease. COVID-19 is a severe illness, particularly in the older populations and those with comorbidities. And yet, the level of caution that seems to be associated with these viruses, with these vaccines, is sometimes very difficult, certainly for me to understand. And as I'm giving this talk, you just need to see the context of that. So why do we need information about vaccines in special groups specifically? Well, part of it has been a little bit like I reached out to all of my vaccination friends and said, are these people, why would a pregnant woman's immune system be different from a non-pregnant woman? Why would a child, we know children have normal, sometimes supernormal immune systems. Why are we testing in adolescents? Why is this huge focus on, why can't we just take adult data and extrapolate to these other groups? And for the immunocompromised, what's going to happen? That we do this in HIV all the time. We give vaccines. The worst that's going to happen is they don't work. And in the background, having seen this in HIV somewhat, is you do kind of worry, isn't there a whole movement to just keep ourselves busy as researchers? Well, the vaccinologists actually did say to me is that in many ways, particularly in adolescents, they don't think there's any reason to repeat studies. Once you've got the data, you can actually tell one out there. They did point out that children do have different dosing schedules and that the safety issues might be an issue. They also said that, with pregnancy, they actually were much more bullish, the ones I did speak to, and they said that really the same concerns as you have in antiretroviral drug development, which is about safety in mothers and particularly in fetus, and particularly when you're using live viral vector vaccines was there. But they actually thought that the data that we needed could come, and that in the meantime, because COVID-19 is so severe, they could run it out. And with the immunosuppressed, there was, and this includes the elderly who have immunosenescence, there is safety concerns with the viral vector vaccines, although I think, again, this was starting to fall away. But there were questions about what is the dosing regimen around how to get optimal immunity. And they pointed out that many of the vaccines obviously have different dosing recommendations. The mRNA ones given twice, and some of the others as well, like AstraZeneca, while others such as J&J just given once, that there might be different ways to dose these around there. And I think that we've seen this with the rise and the recognition the last few weeks of mixing and matching of different vaccines. And what they also pointed out to me, which I did not possibly realize it for people with HIV, but with all these groups, that they are relatively under-vaccinated. When you look at the guidelines and how many people, vaccinations are often pushed very hard, for instance, in pregnant women, and that doctors, for quite complicated reasons, often due to ignorance, but also because of vaccine hesitancy on both parts of the healthcare worker as well as on the part of the patient, and for all sorts of poor guidance, and the fact that people often aren't familiar with the vaccine schedules, that these groups are often left under-vaccinated. So let's start with pregnancy, and it's always a thorny group for drug development and obviously for vaccine development. And part of this is that it's much easier for a drug company when they're doing the development of a drug or a vaccine to just exclude pregnant women. It's an extremely emotional area. Litigation across the world against obstetricians and pediatricians. And the same goes for pharmaceutical development. It's often easier, sorry about the typo again, to exclude these patients than it is to just include them, and do them later on and let observational studies like sort out the mess. IRBs, ethics committees, have also been very risk averse, not just with pregnancy, but with other groups where they are protecting children, for instance, or adolescents or pregnant women from the side effects. And while it comes from a good place, it often means that this group, that these special groups are understudied because of this. What this translates to is that often it's just left up to observational studies and occasionally some brave independent researchers who are willing to do randomized studies on these groups to start piecing out and teasing out the around safety. And we saw it in pregnancy-induced hypertension, eclampsia. It took decades for people to work out which were the optimal treatment regimens in these groups because it was so hard to do studies there. So it's thorny and it's difficult, and it's certainly not made easier by the research environment that we often find ourselves in. However, it has been recognized that COVID-19 actually has worse outcomes in maternal. Now, COVID-19, for the clinicians on the group, there's a myriad side effects and things that go wrong, that not just the mortality and the respiratory consequences, but everything else. It is an incredibly complicated virus, and it seems to be even worse in pregnant women. There is now described, as you would probably expect in any disease that causes hypoxia, increased preterm delivery in terms of the fetus, and there are hints from various observational studies, still quite small, that there might be other things that might go wrong, that these kids might be hit with other side effects from mom having the virus during pregnancy. And as yet, we have no teratogenicity signal, and obviously there that database will steadily get greater and greater as the virus tears its way still through the globe. So the viral, interestingly enough, and I spoke to my vaccine friends and did reading around this topic, the viral vaccine, the vector that we use, the adenovirus vector, is actually being extensively tested in pregnancy in all trimesters. And all my colleagues were very, shrugged their shoulders and said they actually think there's enough of an evidence base for this now to proceed without having to worry about safety issues. And particularly in the Ebola virus crisis, where an adenovirus-linked vaccine was looked at, as well as in others, this strategy, I think the safety of it has, the researchers seem to be much less concerned about this than they might have been 10, 15 years ago. And I think also with vaccinologists, it seems that the traditional inactive and mRNA vaccines are regarded as safe. There's no reason to believe that they would somehow cause a side effect in either mom or the unborn baby in terms of its of anything from teratogenicity to side effect profile to potency. So at the moment, most safety data is coming from observational data, not from actual studies, and that's very similar to all pregnancy studies, including in HIV, where, and as I've said, Jane, same as in most drugs, but it doesn't get tested formally, it tends to get tested as an afterthought. And COVID-19 is meant, because it's so severe and has such consequences, that there has been some urgency and recognition attached to this, and the vaccines recommended during pregnancy quite quickly, simply because the infection is severe during pregnancy. We do have animal models from 3 of the major companies. I couldn't find the animal models for the others, but they might exist. And it didn't seem to demonstrate any safety concerns. Again, the vaccinologist said, yeah, this is kind of routine stuff, and that they weren't surprised that it was going to be safe, and they're all very, very reassured in the process. And at the moment, I went on to clinicaltrials.net, and there are at least 20 observational studies I can see, international registries, breastfeeding studies that are ongoing looking at this group. So there's going to be continual data entering into this field from quite large studies going forward. I found only one study, specifically one ran RCT, looking at pregnant women. There might be, as I said, there might be others that are in design and are about to, and this one is about to recruit. And this was, interesting enough, an RCT versus placebo. I find it interesting because I think there's a debate at the moment going on about whether placebos are actually ethical in the context of COVID. But to their credit, I think this drug company Pfizer actually really have been quite bullish about looking at subgroups and yeah, obviously in pregnant women. The clinicaltrials.gov talks about randomizing 700 women. The press release talks about 4,000, so there's some sort of disconnect there. And also, interestingly, they're not looking at efficacy, they're looking at safety as the primary endpoints. Second, protection from disease is coming to the secondary endpoints. So I think the bottom line is lots and lots of attention is being paid here, and in some cases directly from the pharmaceutical groups. And we can anticipate a lot of really good high-quality data coming here to reassure us that what we're doing at the moment, which is giving these viruses, these vaccines to pregnant women, is safe. And this paper, which came out in NGM just 2 months ago, is a preliminary cut through the data, looking at over 35,000 women who were given the vaccine during pregnancy, and didn't show any overt concerns. There have been other studies as well in terms of the breastfeeding, demonstrating that adenovirus, those who've given the live adenovirus, didn't transfer across the baby. Again, as expected, because that's inactivated viruses, the viral vectors. But the antibodies did transfer. Again, there's no big surprise here. This is what happens with natural infection or with other vaccines. But there was a very good podcast that Rochelle Walensky was part of, the new director of CDC, who talked about the difficulty of doing these safety studies in vaccines. And obviously, America is particularly litigious and particularly careful, and it's a very reflective podcast. I mean, not just with her, but with other vaccine specialists that I would point you towards, that if you are interested in the field, to go and listen to. And talks about the difficulty of doing these studies, but also advocating that they get done as quickly as possible in women of childbearing potential. The important thing about this Pfizer vaccine study, though, is it's only being done in the 3rd trimester. And, again, it's important to understand that is quite risk mitigated. That's the least risky group to actually do this in. And we're still probably going to have to rely quite heavily on observation studies of women who get pregnant just after they've had their vaccine. So over to children and adolescents. This is actually a very short thing to talk about, because Here, paradoxically, it's the same with diseases like chickenpox, for instance, but the risk of severe disease is manyfold different in children. They seem to shrug off this virus with a great deal of ease, much like we do with all COVID. We've all been exposed to coronavirus as children, built up our immunity to them. Probably before the age of 10, we've been exposed to all the circulating coronaviruses. And in many ways, this is probably what's going to happen with this one. Children will get it at an early age, unless they're vaccinated, shrug the virus off and have enough immunity to counter the repeated assaults by that coronavirus going through their lifetime. However, it has been recognized that, and I think people have seen these high-risk cases of, or these cases of inflammatory syndromes and things in children. So it's not as if there's no consequence. And in fact, pediatricians have been quite angry about the fact that children are being excluded from COVID-19 vaccine programs, saying that there's enough actually there to justify vaccination. We completely acknowledge that it's many folds, logarithmically more dangerous in older populations and those comorbidities, but don't forget the children, because there are consequences. And as I said, this immune system just seems to be primed much better to deal with this coronavirus. And when I looked at clinical trials, there are a large number of studies into less than 12 years old, which is the group that we're really worried about. As I said, the vaccinologists seem to think that adolescents can be treated as adults. There are obviously consent issues in terms of the studies, but other than that, we can extrapolate that data across adolescents without any really real problem. The thorniest group I found, though, were the immunosuppressed, and people have got various forms of immunocompromise. And it's important that there's a huge range of immunosuppression. There's HIV, and within HIV, there's treated HIV, where the immune system is almost back to normal, and there's untreated HIV, where obviously there's huge consequence. But there's also minor immunosuppression. People who might be taking inhaled steroids, for instance, or low-dose methotrexate for their rheumatology, are very different from patients who've been coming out of a stem cell transplant, who've been exposed to massive levels of chemotherapy. And there have been, within those groups, or that I was just talking about, there have been these concerns about what's our dosing schedule. There is also a concern, there's this, it's in preprint form at the moment, but a patient in KwaZulu-Natal, which looks very similar to an oncology patient in the northern US, where these patients didn't get rid of, they got COVID and they didn't get rid of it. And there's a concern about these immunosuppressed patients, which to my mind is a little bit over the top, to be honest. I don't, slightly hysterical view of these, that these patients who do not clear COVID, that continue to grow COVID in themselves, are not able to shed it because of their immunosuppressed status, are going to be the petri dish for the next variants. Both these patients demonstrated lots of mutation of COVID inside themselves while they had their various forms of immunosuppression. The patient HIV, which I've read the case very carefully, had a very low CD4 count, was failing their first-line antiretroviral therapy, and demonstrated significant mutation during the 100-odd days that the patient, before the clinicians finally got on top of their virus, and the patient cleared the virus very, very quickly. So there's this thought that a large immunosuppressed population, say for instance South Africa, where HIV is a big deal, might be fanning the variants. I think a much bigger issue is that these patients don't know whether they're going to get a vaccine that works. Now, we're increasingly clear that this virus is probably going to circulate, that the vaccine will stop you from getting sick and hopefully will even have a significant impact on you getting infection. But breakthrough infection on the vaccine is almost routine. We've seen it in South Africa with the J&J vaccine at the moment, which was administered during 3 or 4 months ago to all our healthcare workers. And I personally know of 20 people who had breakthrough vaccines, infections after they were vaccinated with the J&J vaccine. We're starting to see it with the Pfizer one. We're in the midst of a terrible, terrible third wave. So it's quite clear that we don't expect in people who have normal immune systems to have complete immunity from the virus. But for what that means is that there's going to be lots and lots of circulating virus for people who do have immunocompromise. So if they are more at risk for getting sick, or even just normal sickness, and they can't get the benefits of the vaccine, that's a terrible place to be. And that means they're never going to be safe. And this is why this group, in particular to my mind, is probably, of all the special groups, probably the absolute priority in terms of trying to show some efficacy. And for those of you who want to read an absolutely heart-rending story, this is an infectious diseases colleague of mine who's in San Francisco at the moment, that worked in KwaZulu-Natal in South Africa for years and did amazing work. And she's on one of these wicked mAbs that are profoundly immunosuppressive for a very complex autoimmune disease. And she says, when I'm not seeing patients in the emergency room, I help train college students to go door to door to register people for the coronavirus vaccines. They practice again and again. I'm so proud, and again, still at delivering key messages. These vaccines are so much better than the flu shot. They're almost entirely effective at preventing hospitalization and death. So she's in the midst of it. She's working in the casualty. But for her, they measured my T-cell responses after vaccination, and my immunological responses were totally lackluster. This is after several vaccination schedules, by the way. Both the level of antibodies I generated and my T-cell responses were far too weak to offer any assurance of protection. So she is, the way we all are until we vaccinate or have had our primary infection, completely at risk. After arrival of SARS-CoV-2 vaccine, my friends now hiking Hawaii, whitewater rafting in the Grand Canyon. They date people on Tinder without a second thought and gather for birthday parties. For me, it feels like the pandemic might never end. She is sitting there waiting for her COVID infection because the vaccines don't work with her. And if we demonstrate, probably the group which has been most concerned in terms of looking out and reaching out to me for help has been patients on immunosuppressants. And as I said, that varies from everything from HIV treatment to methotrexate to the mAbs, to the potent immunological sort of devastation we see with stem cells treatment and oncology. Having said that, the data at this point is relatively reassuring, and it seems that in the elderly, while they do seem to have some evidence of immune senescence, it does seem that the vaccines are pretty good. They really seem to be working, having a profound impact on mortality and morbidity. So for what they're purpose for, which is hospitalization and mortality, they seem to be doing the job. It does seem that some vaccines might be better than others, but honestly, it's a bit of an embarrassment of riches when you're starting to say this one might be 97% and the other one might be 94.7%. They all seem to be pretty good. It does seem that HIV does increase your risk for severe disease. The limited data we have so far, mainly from South Africa, from two of the vaccine studies, is that the vaccines do seem to work. They might work a little bit less in terms of breakthrough infections, but in terms of protecting from severe disease, they seem at this stage, we haven't seen any increase in the numbers, but the numbers are pretty small. We do know that HIV positive people are at increasing risk for severe disease. There's a large, amazing study in Cape Town with a couple of other observational cohorts, and that risk is the equivalent of being male. So it doubles. So if you're having HIV, does increase your risk of poor outcomes on COVID-19, but it's off a quite a low base. So with a little bit of luck, HIV positive people can anticipate the vaccine is going to work for them. And that's the slight increase in severe disease will be mitigated. And we haven't seen we've seen small case series of people where there have been breakthrough infections who have done badly, but nothing at large scale to demonstrate that there's some mass increase in mortality in people who are on steroids or on other forms of immunomodulation. But that data will come. And obviously, there might be a huge case report reported tonight that might think. But the fact that we have so many people on these immunosuppressives and we haven't had reports yet is slightly reassuring that the vaccines, that at least the virus isn't going to cause huge mortality. We still need to know whether the actual vaccines work in that situation. And the data, obviously, there are far less people who are on severe immune suppressives. And unfortunately, there's no data I could find on these patients other than these case reports, like Lindsay's case that was reported in that heart-rending case report I just read out, on these, other than specific small numbers of patients. So I'm hoping that going forward that this will be looked at. It's increasingly becoming important because it does appear that there's a move towards using booster vaccines. People who've had previous infection or have the current crop of vaccines, that we may need top-ups in certain groups. And the first group that looks like it might need to be done is in the elderly and those with comorbidities, to just increase your risk of your protection level from the risk of the severe consequences of COVID-19. So in conclusion, the preliminary results are very encouraging in pregnant women, and there's little reason to think this vaccines won't work in children, but there are actually studies specifically looking at it like that, and some of those are being funded by pharma. So in these two groups of patients, I think that it's promising, and there's, as I said, very little reason to think that the vaccines won't work. However, we do need urgent focus on immune compromise, and that includes the mixing, matching sort of strategies around vaccines, but just documenting what's going on here. We cannot have a situation where these people are, especially if the coronavirus is going to circulate, that they're just going to be living behind closed doors until they finally get the virus and then have to deal with it in a largely vaccinated world that can continue with its lives as usual, and that they can't. And finally, I think that future vaccine work does need to think about these groups from day one, and that they shouldn't be regarding them as an afterthought. That the second we had data to suggest that that these vaccines were working, that these studies should have been fast-tracked straight into. And in HIV, there's been a lot of anger at the fact that pregnant women in particular, with women in general, were seen as an afterthought once the studies were actually done and the drugs were registered. And I think that we need to be putting a lot of pressure on drug developments and vaccine developers to pay attention to this going forward. And that's all I have to say. Thank you so much for your attention. This is the amazing team I work with who are doing incredible work on COVID in the height of the third wave, looking at novel treatments and prevention strategies in our local population. Thank you so much.